Well, welcome. Thank you for coming. And my name is Peter Kern. I'm the director of the Global Public Health Program, and this is the latest installment in the Global Public Health Lecture Series for spring of 2018, co-sponsored by the Global Public Health Program, especially the External Advisory Committee, and also the Institute for Health and Humanities. Before I forget, there's a sign-up sheet for students and for members who aren't students who are here tonight. Please be sure to sign up before you leave tonight. So tonight we have a very special program for you. It's a grassroots program. So, you know, one of the things that we like to focus on in this lecture series is to showcase the amazing things that people from Montana mostly are doing around the world in terms of global health. And so we bring in some pretty high-level professionals to talk about that. Tonight, we have the great opportunity to listen to a couple of our own students, in fact, students who happen to be in my class right now, one of my classes. And they are coming here to talk about their experience as members of the Global Grizzlies. And I'm sure you'll hear more about the Global Grizzlies in their presentation in Uganda last summer. So Andrew Honikin was born and raised in Frenchtown, Montana. He chose to come to UM because he was offered a presidential leadership scholarship. He's a human biology major and a minor in global public health. He plans to go to medical school and earn a MPH. After graduating in June, he will begin 2 years with the Peace Corps in, of all places, Uganda. And he'll be working in community health, as a community health educator there. He spent a month last year in Uganda, and he's going to be talking about that along with Teague and the impact that that experience had on him. So for Teague, he never gave me his bio, but it just happened that there was a front page story in the Missoulian this week about him. So I guess we don't really have to say very much more. You could just go and read this story in the March 5th edition of the Missoulian with great picture. And one of the things I was really, I have to tell you, I was really pleased about in that story is that you mentioned that you're a global public health minor, and that came out in a couple of places. So, you know, he's really had an amazing experience, and I urge you to read all about it in this edition of the Missoulian. But with no further introductions, I turn it over to the two of you guys.
Awesome, thanks, Peter. Yeah, so we're going to talk about our trip to Uganda last summer. Michael went with us. We had 8 other members. You get to see them featured throughout this, and kind of talk about Global Grizzlies in general, what we do, what we're striving to do, and where we see the group going in the future. So without further ado, and by the way, there's a lot of pictures featured throughout this presentation, so that's kind of, we liked our pictures, I think. So our mission with Global Grizzlies, I have this up here, form lasting cross-cultural relationships, and I have that lasting in there in parentheses because I think historically it's been to form cross-cultural relationships, but it is Global Grizzlies, and we've been sending people to different countries every year, different places, working with different NGOs, and talk a little bit about where we're going with it now, but we're trying to turn that less into just forming cross-cultural relationships and really making those some lasting ones. And for the students that are involved like us, I think the big thing is that an experience like this, when you're a pre-med, you don't get a semester to go study abroad and go do something. So this was a really good opportunity for anyone in pre-professional, anyone in healthcare related, public health related, that have those rigorous course schedules to fit something in and go have an experience and widen their perspectives of the world and really learn about how healthcare is done, I guess, in a place that's completely different than where we live. And so that's going to be kind of a lot of what we talk about today. And then, you know, I think a big part of it still would be to have an impact in some way. And as undergrads, pre-meds, you know, we don't have the professional skills that I'm sure a lot of other speakers in this lecture series have. And so I think we do have an impact, and we'll kind of talk about the way that we think that happens. And, you know, it may not be huge, but an impact's still an impact. So that's kind of general overview of what we think Global Grizzlies is all about. Here's our friend Michael. And so general outline, kind of talked about this. We're going to start out with what we did in Uganda. We're going to then go into kind of what we learned from those experiences, and then finally finish off with where we're going next ourselves and where we're taking the group in future years.
So just talk a little bit about the background of our trip and kind of the work that we had to put in behind the curtains to be able to go on this wonderful trip of ours. So we like our dates. The day of our trips were May 16th to June 18th last summer. So pretty much right after school ended, we packed our bags and we shipped off for Uganda. Prior to that, though, there was lots of fundraising, pint nights, just any way to help our financial contributions for this trip. So we didn't have to, I guess, pay all out of pocket as some poor undergrad students. So that's what we had fun doing I think we got selected for Global Grizzlies in October, late October. And then from pretty much then on, we just kind of started making connections with each other, started working on lots of the fundraisers that we did. A lot is like fundraisers around the community. And yeah, it's kind of all just led up to the fact and led us to go on this trip and have a good time and experience lots of medicine from a different viewpoint. I think it was really touching for me, I guess, from that aspect. Like it hit home a little bit. So we'll get into that later, though. Don't want to talk too much on that right now. And then also, if anyone in the back can't hear me, just let me know. I feel like I don't talk super loud, so just let me know if you can't hear me at some point.
Might have to click one more short video that one of our group mates put together. Hopefully it works.
I don't know if there's a sound.
That is not going to work. All right, we'll try to figure that out at the end, but cool video so that you don't just have to look at still pictures. So I think anyone who knows anything about Global Grizzlies, I think they don't really know that much about what the group does, and there's a lot of misconceptions that get created throughout the university and throughout our community about what we do. And one of the things, just talking to professors, talking to anyone about Global Grizzlies, students that are interested in it, I think there's a big misconception that we get together, we pick a country, we find a hospital, and then we show up and we're just there and we start just doing stuff. And that's really, it's a lot more planned out than that. And so we worked with an NGO to get us settled, have a place to live, give us meals, get us set up with internships within the hospital that we're going to be working in. And so the NGO that we decided to work with was Experiential Learning International, or ELI, and it's just a small NGO based out of Colorado, headed by a professor down there at UC Boulder, who kind of started to get away from his teaching responsibilities and decided he wanted to help students really have these kind of experiential learning experiences and get out there and see the world. And so they send people all across the world, and I think on their websites like 15 different countries with different locations, and they set you up with locals who have reached out to him and asked him to bring students to their community, to bring whatever skills they can have and that cultural interaction. So we were set up in Iganga, Uganda with a local. His name was Michael Kaidiwa, and him and his family hosted us for the whole month and cooked us food, taught us about the local, even he was teaching us because he's super involved with the politics and all the different aid work that goes on there, and he's a huge community member there, and so we were able to link up with him and learn a lot from him just about general Ugandan culture and general aid work that goes on in Uganda. So I think we just want to start out kind of saying, like, it's not just like we show up or pick a country and go somewhere. It's a lot more thought out than that. And yeah. So for anyone who's geographically challenged, this is where Uganda is, the Pearl of Africa, headwaters of the Nile, right there, right above Lake Victoria. And then within Uganda, international airport is in Entebbe. So we all flew in there. We actually flew in 2 separate days. Me, Teague, and one other member got to spend the night in Entebbe and just be there by ourselves, which was interesting, and go like see a zoo. Then once everyone showed up, we took the like 6-hour drive. It takes about 2 hours just to get through this star in Kampala because of the ridiculous traffic. But then we made it all the way up here to Iganga. So Iganga is a city of about, I think it's a tiny bit bigger than Missoula, but it's a lot more spread out than Missoula. So there's just houses that look like they go forever. And so I think it was right around 80,000 people, but just imagine the size of Missoula geographically times like 5. And that's kind of how spread out it kind of gets. And yeah, so we weren't way out in the boonies, but we weren't in like capital city in like Kampala is almost like, it's like Seattle, but then slums on the outside.
So I kind of just want to give a little basis and understanding of background information about the Uganda educational system. It starts out with primary school at the age of 6. It doesn't. That's like the general age when the kid starts, like 6 or 7. But there are kids who can start at like 8 or 9. So it's kind of just like different in that aspect that it's like, yeah, you can start at this age, but it's not like all kids are the same age as you at the primary level. So it's probably like it says primary level goes for 7 years. So that's kind of like our elementary school, I guess, a little bit. And then you go into secondary school. And in secondary school, it's weird. They have this thing called A level and O level. And O level is 4 years long, I believe, right? Yeah. O level is 4 years long, and then you can kind of graduate high school. But if you're an exceptional student, you are part of A level, which means you go an extra 2 years of secondary school in which you learn like specialized education, I guess, in a sense. Like, to give you an example, if you were an A-level student for biology, chemistry, physics, I don't know if it's like this today, but like 10 years ago, you only could go into medicine after that. So you can or medicine or dentistry. So as like an A-level student, you kind of like become specialized, and then you have like a road that's kind of made for you when you go to university, which is after primary or after secondary. So university is kind of like our college. They just call it university. And that's pretty much like 4 years. But then you get like, so for the people who are like BCP A level, they then go into medical school, which lasts 4 to 6 years long. It's 4 years for medical officer assistants.
Clinical officer.
Clinical officer, which is kind of like relatable to a physician's assistant, I would say, to our standards. So they would go for 4 years, and then medical officers, which are doctors, would go 6 years long. And they kind of have like the limited scope of fields like we do, I guess. Not as many specialties obviously as we do, but along the same lines as our med school a little bit in that aspect of like what you can go into. But it's mainly general, like practitioner, like you're a general doctor kind of. There's not too many specialties at this point in their medical field. Yeah, so that's a little bit of background of their education.
So, oh, sorry, I'm just getting over some bronchitis. So, sorry if my voice goes out halfway through this. But, so let's get into hospital life a little bit more. And so, we were working in Iganga District Hospital. And so, this was a large hospital by Uganda country standards. They basically go Health Center 1, 2, 3, 4, District Hospital, Regional Referral Hospital, and then there's one National Referral. And so a health center one would just be like some community health workers working in a remote village. So every village is supposed to have a village health team to help them deal with basic like antenatal care, or if they realize someone's really sick, they need to get them to the big city to go to a health center 3 or 4. And then health center 2s are generally just run by nurses and midwives, and their main concern with that would be doing any sort of maternal care, doing births out in like a larger village. And then health center 3s would have like only a clinical officer, so they'd be run by basically a PA, and they'd be doing little more services, so they'd be able to probably treat any general bacterial infections or malaria and anything that's really we would think of as like an outpatient clinic or walk-in clinic in here. And then health center 4 is where you're kind of jumping into a little mini hospital, and that'd be run by at least like 2 medical officers, so a chief medical officer with someone to assist them, and they're able to do everything at a health center 3, but then in addition to that, they've got emergency care and maybe some more specialized care like ear, nose, and throat or something. And then each district within Uganda is going to have a district hospital. And so we were in the Iganga District Hospital, where this is where there's pretty much any service that you should need in everyday life that you can go get. And so within this hospital, they had male ward, female ward, pediatric, maternity, outpatient TB, antiretroviral, young child care, surgical theater trauma, ear, nose, and throat, laboratory, mental clinic, antenatal care, family planning, and dental. And so they had a lot here. And we showed up and we were like, holy cow, this hospital, like, this was more than we were expecting showing up as naive undergrads who hadn't been overseas before. And it was really cool to be able to explore around in all of these different sections and see how they're able to do these like really technical things with very limited resources and very limited staffing. And yeah, I think that's all I want to say about that. So the facilities, T.
Yeah, we kind of just want to give you guys like some pictures so you can kind of have an image in your brain of like what it looks like when we're talking about some of these places. So like for instance, this room right here, which is kind of sketchy looking, that was a casualty, and that's pretty much like our ER, I guess, to comparison. And I actually spent, I think there was only one night I spent in there. Like I spent in Tucker, the guy you saw sleeping on their slide. We slept in there 1 or 2 nights together, and we just would observe whatever happened. And it's kind of interesting because at nighttime, that's when lots of automobile accidents would happen. And one night when I was there, this girl came in at like 3 or 4 in the morning. She was brought in, and she said that she recently got in a bus accident. And it was weird because we didn't hear about it. Like there was other patients brought in. There was like no other like really people from that accident coming into the hospital, which is kind of weird because it's like the closest hospital to the accident. And she was talking about how like some of the people died in the accident, and she had like a broken clavicle, a broken leg, I want to say. She was like in shock, so she was really hard to talk to. But she also came in with a baby, which was even more extraordinary because I'm just like sitting here thinking like you just got in a car accident, like how did this baby survive? And you talk about like people who died in this accident. So, and this baby was was crying the whole time, and he like wouldn't move his arms and his legs. So I was really like concerned. I was like, there was like only like the doctor on the hand was dealing with the mother because she was more severe and had much more like needs at the time. So I was sitting there kind of rubbing the baby's tummy, just like hoping that he can like move his arms because I was really scared that he might have paralyzed or something. And he like wouldn't stop crying, but he was like the cutest little baby. Eventually, like after rubbing him for so long, he like finally went to sleep and like he rolled over, so I could tell that he wasn't paralyzed. So that was like made me feel bad here. I mean, hopefully it made the mom feel better too, but that was just like touching for me because I was like just like thankful that he was like okay, that she was okay, and like they could, get treatment at a hospital and just be fine, be healthy. So that was like an experience I had that would last with me forever. So it was really cool. But this is the there's a postnatal, or is it
Neonatal incubator.
Yeah, this is, so we have an interesting story about that actually that comes up maybe in the next slide, I think, or later on that we'll talk about. But this one is their female ward? It looks like the female ward. Andrew didn't work in the female ward, so some of these places kind of look new to us. But this is the male ward where Andrew and I spent most of our time along with Tucker. Yeah, just lots of experiences for us in that building. So
Yeah, it was amazing to see like the variety of facilities they had, where the male ward hadn't been updated for more than 20 years. 90% of the lights in the building didn't work. Like you can see the ceiling tiles missing all over the place. The ceiling was leaking all over the place. But then you could tell where they're really focusing to try to improve with the maternity ward and the outpatient clinic and the female ward, where you had these brand new facilities that had been built in the last 5 years from some World Bank funding that Uganda got to try to improve their maternal services and improve their antenatal services and their young child care and family planning. And so those facilities were really, really nice. But then at the same time, we had I think there wasn't even the right number of beds in the male ward because they couldn't get enough beds that were level or could support a patient. So it was a really big variety where we had this like modern care for a need, like they had a NICU, but then at the same time, like people on male ward or even pediatrics ward, like barely had a facility that looked like it was standing because it had been built in the 1960s.
yeah. Did you want to talk about like levels?
No, that's coming up. And so this is going into that. This is also the facilities of like, this is a memo saying basically they can't do any sort of laboratory testing for anything. So if anyone comes in with malaria, they can't test them. And this was up for like 2 weeks. This is the delivery room where behind this sheet, there's probably 3 or 4 women simultaneously giving birth right next to each other. Like things that you take for granted that our hospitals have here, where it's like, can't have a fire alarm. And so there's a backup whistle for it. Anything like this is showing more wash kit, spill kit, but even like their sharps containers were just boxes that picked up from supplies, and like they really struggled with a lot of this like infection control and hygiene, and like sinks were broken all over the place so people couldn't wash their hands. And so while there was that really nice facility with maternity, there was also just like a severe lacking of funding for some of the basic things that we think are just regular in a hospital.
Yeah, so here is kind of an example of what we did, I guess, as students learning about medicine. But, so this is Amanda up here, and she is, I want to say she was giving CPR to a baby who wasn't, like, they were giving CPR to this baby for like hours on hours, I want to say, because it was just not in the best health when it was born, and there wasn't enough resources, and Amanda was certified to do CPR, so she worked in the maternity ward, so she would help out with taking turns with the staff on giving this baby CPR. I don't remember.
So I think more like this is what people think we do when we go overseas, go do these service trips. They're like, oh, you're going to change the world. You're going to go provide healthcare to these people who have no idea about healthcare, and like go give them drugs and deliver babies and do all these crazy things. And I have this slide up here because that's really not what we did. And this is a very small picture of like Amanda learning to cannulate Michael because he got malaria. And that was like as good as it got for learning actual like medical techniques and helping out. Like we were helping each other out. And like thinking like, oh, we're teaching like doctor. Like, no, we're not. That's not what we're doing. So the next slide, I think, is what we really did.
Yeah, but quickly, really, this is the story I was talking about. Is this incubator was sitting around for like 3 or 4 months before we got there, and like even when we opened it up and we started taking out the tools and stuff, there was just like ants like crawling all over a bunch of stuff, and like I remember I was just like, oh yeah, nasty. But Andrew and I, since like we had some time on our hands, and Peyton came over and asked us if we could put this incubator together. We thought kind of like, why not? You know, it's been sitting there for 3 or 4 months. Who knows how much longer it's going to sit there for? They had like 3 babies in that one incubator that you saw us in the last slide. Like that was only properly like running incubator. There's 3 babies that are fitting in there that should only fit 2. So we were kind of just like, so we took it out of the box and we set it all up. It was super hot in there, and Andrew and I were really sweaty. It's kind of gross, but we got it up, and eventually it was working, and they were using it. So we felt kind of good about that in the sense that we were helping out the maternity ward.
Yeah, I always think like they don't have an IKEA in Uganda. Like they don't know how to like assemble things when they get them in the mail. But it seemed like that was a skill we had. Like I was like, I've done this many times before. I know how to work an Allen wrench and follow directions in English. So it seemed like a good thing we could actually do for them. But what we really did, I think, was interact with physicians, interact with nurses, learn from them, get their experiences, share our experiences with medicine and healthcare in the U.S., and share our perspective of what we saw when they did things, and then they could share what they saw when they did things. And it really created an atmosphere to make really good friends, and it was unique because as undergrads that don't really have that medical training, don't have this already preconceived idea of the way medicine's supposed to work, the way healthcare is supposed to work, we were able to go in with more or less a blank slate and just look at how it was and learn from them. And really, I think they really enjoyed that we were eager to learn from them, and it created this good environment of being able to share with them and create really good friendships with high-level doctors, nursing students, medical students, clinical officer students, like all over the board. With like the last 3 days we were there, it was like saying goodbye to everyone in the hospital. And so that's what I think we really did, was have this cultural exchange and really, before we move off into our respective professional schools, like get a fresh perspective on the way healthcare is done in somewhere that is completely different than what we are going to go into as professionals, and bring that perspective with us going forward as professionals in our future. So what did we learn? We learned the cardiac cycle. Now this is a cool picture, but something like just generally, like if you take anything away from this, these 2 quotes I think really summed up what we saw, what they were teaching us. Like the government will always what? Lack. And the system has what? Issues. Like they recognize it, we could recognize it from a glance, and overall, like since they recognized it, there was a lot they were doing to try to improve that and do whatever they could with the resources they had to make it the best they could. So like T said, we spent a lot of time in the male ward. I think I probably spent 90% of my time just in the male ward. I got really close with a lot of the doctors and medical students and nursing students there. So I decided I didn't really need to go spend a week in male, a week in peds, week in female, a week in maternity. I decided to spend my 4 weeks in male ward, and it was really the kind of medicine that I was really interested in, and so it really fit with me well. And so we're just going to kind of talk about that specifically, because I can't talk to you about what was going on in maternity that well, because I spent like 2 days there. So here goes my description of male ward. So background behind this picture, I was trying to not take any pictures in the hospital, and then last week I'll talk about the presentation we did. The doctor told me to go in and take a picture, and I was like, okay, I guess I will. So this is male ward. I tried to measure in my head based on like looking at the size of the windows, like get a brief measurement, and I wrote down my notebook. It's about 1,800 square feet, and they squeezed 40 beds into that with usually it seemed like at least 35 beds were full of patients. And so they kind of had it split up. This picture's pretty dark, and you can kind of see these walls, half walls that separated into 3 sections. And so in this first section, they really tried to keep patients that they needed to keep an eye on. Because if you're standing like right where I am, this is where the doctor's office is with a big window that they can look out onto ward and make sure someone's not like collapsing. And so within that first section, we had trauma, so like broken legs, a lot of different people with lacerations and assaults, people recovering from surgery, so a lot of like hernia repair surgery, appendectomy surgeries that are just sitting on ward trying to not get an infection, even though it was probably the worst place they could have been to not get an infection. And then like critical patients, so people who came in that were like so anemic they were being carried in by their loved ones. And then the second section was less critical patients, so a lot of old men, a lot of people who had strokes, or we had a guy on there for like a week and a half who was in a coma, like this doubled as their ICU. We had chronic conditions, so a lot of diabetes and neuropathy that had to go along with that. And then also a lot of children. Actually, I'm gonna talk about children later. And then, so it was male ward, but it was any kid that was older than like 12 went to male ward. If they're younger than 12, they got to go to peds ward. And then third row was kind of the infectious disease patients, and then also patients that were dying that they knew were dying, and they didn't want to like have everyone else like looking at them. And so a lot of tuberculosis in that ward, so tuberculosis is just flying around this whole ward, but they kept it in the back just so most people weren't getting too much exposure to it. And then infectious diseases, so that's where they threw a lot of their HIV/AIDS patients that were having exacerbations or in a severely immunocompromised state. And something that I noticed in this picture is like with the TB, a lot of the TB patients we got were actually prisoners. And so there's like actually like 3 prisoners who are handcuffed to beds in the back of a ward right here because it's free healthcare. That's where they take everyone. So prisoners got to come here too and get treated. Yeah. So like I was saying, it's a variety of patients. There's so many different kinds of things that these doctors had to know how to deal with that really required a high level of knowledge. And I was constantly amazed by that the chief medical officer on the ward, his name was Dr. Issa, and he seemed to just know everything. It was like, he was like roasting everybody on questions he'd ask as we went around and did rounds, and it seemed like he just had a general knowledge of a lot of different stuff, and at the same time he was like a specialist that could go do surgery up in the afternoons. And so these guys have this level of knowledge that I don't think a lot of physicians have the same breadth that these guys have to cover in the US. And so that was one of the things that just constantly amazed me, was just the sheer breadth of patients that they're able to deal with, and the way that they're able to deal with those patients with their severe lack of drugs and resources and beds and everything of that sort. So this is kind of just a rundown of like an average day in doing a round in the male ward. Yeah, you can read. Okay. And so then you think of that, you got 40 beds, usually at least 35 patients, but as far as the male ward staff, it was pretty thin. There was a charge nurse that was probably around like twice a week, otherwise she was off doing stuff in the other parts of the hospital. There's one guy that was kind of in charge of being like the mentor nurse, the guy teaching these 15 nursing students that are all here actually doing a lot of the care that's being done on ward. And then as far as physicians go, there was the one chief medical officer, Dr. Issa, who was also like one of the big shots in the whole hospital. So it seemed like he was on male ward for maybe like an hour a day or 2 hours a day. depending on what else he had going on in his schedule. And then really the majority of the medical work that got to be done was a lot of these students and residents that were spending their 2 or 3 months or 6 months, as far as the residents go, getting their clinical hours in. And really the crazy thing that I, like initially at least, that I thought was like, in the US we'd have like a lot of supervision. You know, you're attending with your resident, and then you've always got a physician that's going with the students. A lot of these students here were just like told to go do their work, and then no supervision whatsoever to help them out. So they were really responsible for these patients, and like you saw, like a lot of these patients were very critical and needed good care. And so I was amazed. It was kind of a lottery though with students, because the first 2 weeks we were there, we had these nursing students here who we became really good friends with and were always socializing with us. But they were like 3rd and 4th year nursing students who had a lot of experience, understood how to do all their tasks really well. And then they left, went back to school, and next Monday we come in and it's a completely new set of students. And these guys were like 1st year students put into the same position that these 3rd and 4th year students had been in. And we were following them around, like watching them take BPs, like trying to give them pointers, because they were so inexperienced that it was like us just spending 2 weeks on ward seemed like we like could help them get through a lot of stuff. So it was really interesting to be able to shift from this completely like fly on the wall, like trying to learn everything we can, to being like, oh wait, no, maybe like before you put that cannula in, like wipe that off for a second so they're not going to get a line infection. Like, so it was cool to be around all these students, because a lot of them were our age or close to it, and they were learning all these new things that we were excited to learn about. And since they had just learned it, just mastered it, or were currently learning it, they were very excited to share their new knowledge with us, which just made it that much more of a amazing experience. So daily schedule on male ward. You go ahead, click once, D. So everyone shows up around 9 a.m. I say very roughly because this is Africa time. No one's actually going to be there at 9. Maybe 9:30. We'll see. Like a few people trickle in. A couple things start getting done. More likely, more like 10. So like first week we were there, we were showing up like sharp at 9 and standing around, no idea what to do. And then after a while, we kind of caught on and either would go explore the rest of the hospital or sleep in a couple, maybe a half hour later. And then first thing we did every morning was we'd help the nursing students do their daily cleaning duties. And so we'd walk around with rags and buckets and go wipe off the windows every single morning. It seemed like they had a ridiculous amount of dust on them every single morning. And then go and make all the patients' beds before the clinical officers showed up and yelled at us because the beds weren't made. So we tried to do that as quickly as possible once everyone was there. And then rounds were supposed to be twice a week, Monday and Wednesday at 10 a.m. I didn't learn this till the last week, because rounds were not Monday and Wednesday at 10 a.m. They were whenever the doctors were around and wanted to do rounds. And so there was times where it'd been like 6 or 7 days and there'd been patients who hadn't actually gotten to talk to a physician or like heard any update on their treatment. And so that was an interesting, but ideally we learned in a meeting the last week that they were supposed to be every Monday and Wednesday at 10 a.m. And that last week they were talking about getting back to that. So maybe the next year's group will see that. And then treatment. So treatment happened around noonish, which was weird because that was when we were supposed to go home and eat lunch at our house. And so we never got to go home right away. So we were all starving. But treatment kind of happened at noonish. I'll talk more about that on the next slide. And then lunch, we were eating 1, and it was supposed to be an hour lunch, but it kind of sometimes turned into a 2-hour lunch or a 3-hour lunch, and a few times it turned into the rest of the day, because then in the afternoon, nothing really happened. After about noon or 1 o'clock, what are you doing, T? after about noon or 1 o'clock, nothing happened. I don't know what they did. Like, literally, we'd sit in the office and we'd just talk and hang out. And I would ask, like, is there something like we should be doing? Like, is there anything I can do? And they're, oh, no, there's nothing going on. Like, we're all right. And like maybe like 1 or 2, like they might do like drain a pleural effusion and a patient and go check out one of their really critical patients. But otherwise, it was just kind of like a lot of downtime to just socialize and talk to the physicians, talk to the nurses, and get to know them. And I enjoyed it personally, but looking at like the efficiency of healthcare and these people, like everyone was on the clock, like, it seemed like a very Ugandan way to go about your afternoon. So, yeah. So the treatment, T.
Okay. Yeah. So treatment was, like Andrew said, it was usually kind of done around noonish or supposed to be, but it ended up being like sometimes like 1 or 1:30, 2 o'clock. It was really weird. It was, for me, it was interesting because I really like to be part of a treatment and just like watch them, observe, and kind of help out where I was needed. Especially in the second week, like the third and fourth weeks, like Andrew talked about, when the new students came in. We found out eventually that we kind of actually, like at that point, knew a little bit more than they knew. So it was really cool for us to be able to help them as well as like feel like they were helping us. So it's kind of a symbiotic relationship, I guess, in that sense. But with their treatment, this is the treatment cart that we had like our what they call that,
That was like a sharps container.
so kind of just like where you put all your sharps and anything with blood on it, and then here's like your trash where everything else pretty much went. And they have like, this is like everything that they offered to their patients as far as it went for medicine wise. It was pretty basic. Like up there you can see what they give, like ampicillin, saline was the most like used thing, I feel like, or the metronidazole. It was all just pretty basic in what like they were giving their patients, and it is free, you know. But once they ran out. They couldn't. Where like if there was patients left, they just couldn't help them out. Like they just forgot about them for the day, kind of, I guess, in a sense. But there was also a pharmacy right across the street from the hospital. So if patients had the money, which in a lot of cases they didn't, so it created problems. But if they had the money, they could go across the street or send a family member with a list for what they needed for that day, or any other medications that the hospital didn't offer or didn't have at their own pharmacy. So that was kind of an option for them, but at the same time, like I said, not every patient had enough money or even had family members who could go across the street for them and get those medications. So that's kind of like where, if like it like I said, it led into lots of problems of like, what if the patient couldn't afford medications? There was just like nothing that could be done for them, unfortunately. That's kind of like, I think we both kind of felt bad, like we really wanted to help them and stuff, and like we wanted to like give them money, but at the same time, like we're college students, and even though like to them they think that we're like rich and stuff, the reality is like we weren't. Like we're still pretty poor when we come back to the States. So it's definitely hard for us and hard to see stuff like that when you felt like you could help, but you couldn't. You were just locked up in what you could do. And the same with the doctors. They kind of adapted this mentality though, like it's normal to them. It was a norm. It sucks that it's a norm, but like that's the way it is, and they just didn't like blink an eye about it when it came to stuff like that. And then as far as like treatment-wise, more challenges that were created is the fact that they use very basic antibiotics for pretty much like everything. And the problem with that is that then there becomes a drug resistance that is built up by like the whatever is the virus or that's infecting the patients. So that for like then the antibiotics essentially wouldn't work in the long run because they're being exposed just to more like just it's too general and too basic the way they're doing things, and it just really built up a drug resistance in the viruses and stuff. So that was kind of like what we took out of like the treatment aspect of it. And this is a patient's medical history book right here. And that's like for elementary education, it looks like. But that would really have like the doctors would take it, they would write down everything that they did, you know, when they saw them, like pretty much all full report in these things that the patient would keep themselves and would always need to bring back if they ever went to the hospital. They'd have to find this and bring it with them. And it was kind of weird, obviously, because our like patient like information is kept within like a secure database and stuff like that. So it's just really weird that they have to carry stuff like that around whenever they go to a hospital, I feel like. But it was really interesting, so that's kind of like a little bit behind their treatment.
So the thing that I think excited me most was I was approached by Dr. Issa, the dude there, and we'd gone to this like monthly ward meeting, and they were discussing the death report that these students who had been working on ward for like 4 or 5 months had been working up and writing up and trying to like really figure out why patients were dying on ward. And he asked me if we would like help them do a presentation on this in front of the whole hospital, do a continuing medical education seminar in front of the entire staff of the hospital. And I was like, I guess, yeah, sure. I have a computer that I can make a PowerPoint, like, might as well. And so that night they gave me the handwritten death report that they had been working on for months and asked me to type it up. And so I stayed up till like 1 a.m. and typed up this death report of like barely legible handwriting and barely legible English. That was fun, but did that, and then like brought my computer for like the next week, like trying to like ask Issa like, okay, when are we gonna work on this presentation? When are we gonna do it? Like, he's like, oh, and to this afternoon, oh, tomorrow, like, oh, I'm busy, I got a surgery. Eventually, like, we got together, and me and him kind of collaborated on putting together this PowerPoint to present this death report to the rest of the staff. And so, click on the next slide. We put it together. This is like the opening slide. Used my pictures that I had, and I still am not completely sure what he was getting at with it, but we did a continuing medical education seminar. This is a picture of Issa presenting, because the picture of me presenting was kind of weird. And me, Teague, and Tucker got to be a part of this and present with them and really try to push home some points of issues that these students had realized in their time observing within this hospital, and share that with all these other like 100, 200 people who worked in the hospital. And so, click next slide. Some of the things that they recognized that I hadn't necessarily thought of were these are some of the main points from that report. And so, this first thing, they noticed that patients were dying in the evenings and the night times, and this was partly due to that treatment plan that the male ward had initiated, where they gave treatment to everyone at 1, and then they gave treatment again at 7 or 8, but that was even less of a reliable treatment time, and then they gave it again sometime in the night at like 5 in the morning. And a lot of these treatment schedules were getting skipped because there wasn't good coordination between the different shifts on male ward of saying, okay, this guy needs his metro at 8 p.m., this guy needs his artesunate at 5 a.m. And so they noticed that. Out of the files that they reviewed, 4 of them had no physical exam, so they got admitted onto ward and then never got looked at until it was time to actually get treatment. And so they weren't really getting diagnosed with much as far like, and so then these patients, as a result of that, like no one realized how critical they were, how bad a condition they were in, so then they didn't make it. And then almost none of them had a reading of blood pressure. And so this was something that was supposed to happen every morning with those morning duties. The nurses were supposed to go around and check every blood pressure of every patient, make sure no one was about to die of anemia or anything like that. And so it was amazing that they reviewed 9 files and only 1 person even had, like some of these patients were on ward for over 2 weeks and they didn't get their blood pressure read a single time. More than half of the files had, this was them kind of playing the classic doctor trick of blaming their death or anything on the patient themselves. And so they're saying they didn't adhere to this prescribed antibiotics and treatment plans. But what really eventually they kind of recognized at the end of the report was that part of the reason for this was that the hospital didn't have the stock, so they ran out of the stocks halfway through the treatment plan, and then the patient, like he was saying, couldn't afford to go buy their own. And so, yeah, I really enjoyed presenting. I don't know what Teague felt about it. He was
It was
kind of
yeah.
thrown in. I included him into it.
Yeah, I was really kind of like told at the end of the presentation, like, oh, you're part of this. And I was kind of like, what? Like, he told me I wasn't. Like, Dr. says, like, one Andrew only kind of. And then the day it came to it, he was like, what are you guys doing? Like, you're all part of this. So I was kind of like, okay. So we got up and, like, presented. It was really cool. I felt, like, the coolest thing about, like, all of it, I thought was, like, they treated us like we were professionals. And it was a lot different than how it is over here, where we get treated like we're kids and like these undergrad students. Like, a lot of people in professional, or like our professional programs, like see us as kids. And I just like the aspect that they treat us like adults, they treat us like professionals, they talk to us like that we had like a piece of information that would be important to them to share, I guess. So that's what I really took from the experience and liked about being included as part of that death report meeting, I guess. So here's where I get to spiel about brushing your teeth and flossing. Just kidding, I'm not doing that, that's boring. I'm gonna do more of like what I did, because I did do a lot of observing in the dental clinic, since that is what I'm gonna do for my profession. I think Michael came in one time with me. I don't think Andrew ever came in with me at all. I think I was able to pull Tucker in one time. I was trying to pull these guys into my little field a little bit more, so maybe entice them to go to dental school with me. I don't know. Didn't work out though, because they're not doing it. So, but this is me and Dr. Paul. He was the lone dentist at the Uganga Hospital, and he actually lived in Kampala, and I think he worked 3 days out of the week at the Uganga Hospital, so he would travel from Kampala by bus, like, to work 3 days of the week there, and he had a private practice back in Kampala that he would either work 2 or 3 days a week as well there, I believe. His family had a car, but he would take the bus because his wife would need the car to take their kids to school and whatnot, whichever she did do in Kampala. So he would just take the local transportation to Uganga every 3 days of the week. I think sometimes he would stay there for like two nights or something. Like, he would stay at the hospital. They had places for him, like, where staff members could stay, and then he would like come back on another day. Like, so he traveled there twice a week, I feel like, roughly. It was weird though, because it's Africa. Sometimes he would just come on days that he told me he wouldn't be there, and then I'd see him walking around and be like, Dr. Paul, like, what are you doing here? He told me we were gonna come, and he's like, oh yes, they called me and said I needed to be here though, so I came. And I was like, so there's no schedule really made up. It's kind of just like they call him if they need him type thing, but he also shows up on his own as well. But he was like a really fantastic man. He really learned a lot from me, and I learned even more from him, so it was really cool. It was like that, keep on talking about symbiotic relationship, where they want to learn just as much from us as we did from them. So I shared with them my experiences, the knowledge to the best I could of like dental school, or dental practices in the U.S. So generally, like, I just want to, how many people have seen this before, this chair? Everybody? Has anyone not seen a dental chair before? No? I didn't think so, because they're literally like, people come in and try to put like their feet up here and their head down here. So like, that's their dental education. Like, they don't even know how to properly get into like the equipment, you know, like just the chair alone. And I was even more amazed that they had this. They have like all the state-of-the-art equipment that they needed to do fillings. They have everything to do for root canals for the most part. They don't have like microscopes and stuff like that we have at the endodontist could do, like more special root canals, but they have like, as far as you need, like for basic general dentistry, they have it. It didn't get used ever, as far as I was there and watching. That's kind of another challenge that we'll talk about a little bit later. But this was their second like makeshift chair. It's kind of dark, you can't really see it, but it was really, I just called it, like, my word for Uganda was just like janky. Everything was kind of janky and just like put together and just like not like looking nice, but it worked. That's like the thing about it, is like it all works. So I always called it janky just because I thought that was a good word for everything. But they have one dentist. They call them dental surgeons in Uganda, but just what we know as a dentist, a general dentist. One dental assistant who was there, and she would kind of be just like what a dental assistant would be here, and just be an extra pair of hands for the dentist to perform all what he needs to do. They had two, what I pretty much know as extraction specialists. They call them like dental assist, not dental assistants. They had a special word for them, but from my understanding, they were pretty much just two staff members who could do extractions, but they had to be supervised by the dentist. So like sometimes that chair over there, like I said, it was primarily used like to give shots of lidocaine and mixed with epinephrine for pain. But sometimes the dental extractionist would like be in there doing extractions while Dr. Paul was in the other room doing some kind of observation or something more special that he needed to use the chair for. But for the most part, like it was the chair where you're doing most of the procedures. Dental, well, I guess let me go to the next slide first. So kind of like their challenges is literally pull it was the solution for everything. And I mean like I said, I didn't see a dental filling while I was there. And it was super weird because they have like the state-of-the-art equipment and everything they need to do it. It's just, first of all, there's no education with the patients and they don't understand, all of them understood like if you pull your adult teeth, they don't come back. Like some patients would think that they'd come back again. It mainly comes down to the fact that most of the patients were just too poor to afford anything other than extraction. I think we'll get a little more in the next slide about that. Lack of oral health care, or oral health care education, like I keep saying. Many of them didn't brush their teeth and even know what flossing was. It's become a bigger problem because there are a lot more sugars and like carbohydrates introduced into their culture now. So they're seeing lots of more cavities roll through and it's becoming more prominent. So it's like, that's what Dr. Paul and I talk about all the time is like, how do we get these patients who are out in rural villages to become educated on oral health care and understand the actual importance of taking care of your teeth. And, you know, we talked about like videos and stuff like that, but the hard thing that he kept telling me is like, even if you send me videos about how to do it, how do we display it to people when they don't have like TVs, or how do we get a translator to translate what's in English into their local language? And they have, what, like 67 languages in
32.
32, that's too far above. They have a ton. I thought they were speaking just random language all the time. But 32 languages, so that it's hard to translate into creating these videos when you don't really know, well, like, we don't know anything about those like languages, like how, we don't know if there's words to describe what we're trying to describe in that language. So there's just lots of challenges that I think you could think about and predict, but like even more so, like you don't think about a lot of these things when you like, in comparison to us, I guess. Like it sounds easy to make a solution, to recommend a solution, but then you're thinking about, well, is it actually like feasible with their resources and their education as well as dentists. So the limited supply of lidocaine was also a big one. Once they ran out, they just ran out, and it was kind of like, as a patient, you either just get your tooth pulled still regardless with the pain and everything, or you come back like next tomorrow and see if they would have more lidocaine. But like we said, some of these people are coming from rural villages that they just can't come back again like the next day, so they have to just get their tooth pulled without lidocaine and epinephrine. So those ones are kind of a little bit more harder to watch sometimes. Their sterilization techniques were very interesting, to say the least. I'll go back quickly and show you. If you didn't notice, that is a sterilization. I even like how you define it. Like it just, yeah.
Sterile field.
The sterilization.
Sterile field.
Well, no, like the actual like.
Oh.
You see like that? No. This is actually like a sterilizer.
Oh, a sterilizer.
Yeah, like this like is what like your dentist would have at their office to sterilize. Like, you know, when they pull their packages and you think like everything they have is new. At least I don't know about you guys. I thought that as a kid. That I can realize that actually they're just sterilizing it and repackaging it, which makes sense because they need to keep it in a sterile field. So they would have a sterilizer, but you learn that after being there for a while that they would only sterilize like once a night maybe, or maybe not even that, I don't know for sure exactly, but whenever like that day people would start coming in, they'd pull out the pliers whenever they're using to pull teeth, pull the tooth, discarded it properly, and then just like the dental assistant would grab the tool, walk over the sink, wash it off, scrub it with like maybe some little bit of soap, put it back on the tray, use on another patient. So obviously you see that creates problems with sterilization techniques, and that's not how you would want it even that to be done, kind of, I guess. But they don't have enough resources, not enough tools. They kind of just like the way they had to do it, and I didn't say much about it, obviously, because I don't really know about like if there's a better way for them to do it. I was kind of observing. I wasn't trying to step on any toes and say like I had all the answers, because I definitely didn't. But yeah, so that's their problems with their sterilization techniques. The biggest thing is probably that there's one dental surgeon for 170,000 people, or one per 170,000 people. I think Dr. Paul told me that there was, at the time I was there, roughly around 245 dentists in all of Uganda. Most of them would go into private practice because that's where the money's at. Unfortunately, that's kind of how they see it. That's why I was pretty hesitant. I don't know about Andrew, but I was pretty hesitant to say how much like doctors or dentists would make in the States, because I didn't want to say that and then have them think in their mind like, oh, they're making lots of more money over there. How do we get there and become doctors there and like do practice over there? Because I'm not a person that's really about the money. I hope to go into public health. I'm a dentist. I don't want to do private practice. I don't want to try to make as much money as possible. I just want to educate people and do a lot more in public health. So I stayed away from talking about stuff like that. Whenever they asked me questions about it, I would just kind of tell them I didn't really know and just kind of try to sneak around it a little bit. So a little bit more about their dental challenges. Obviously, orthodontistry is a big thing over here. Over there, not so much. 2 to 3 orthodontists for the whole, specialized orthodontists for the whole entire country. Dr. Paul and the dental surgeons they can do orthodontistry. They're not specialized, but they can do it. It's still in their repertoire. I remember a case of this girl came in. I can't remember exactly what it was. She had overcrowded mouth or what was going on, but her like front teeth like collided with each other. And Dr. Paul was talking to the father of this child, and he was pretty much saying like, yeah, we can do orthodontics. Try to explain to this guy, first of all, what orthodontics are. Explain the whole process. Like, that's one issue in itself, is just trying to explain all these things to these people who don't even know at all what you're talking about. So try to simplify that for them. Talk about, yeah, she's gonna have like these metal brackets in her mouth. It's gonna take like 3-4 years over there to do. We sat there for like 45 minutes explaining to this guy exactly like what Dr. Paul was talking about with orthodontistry. This girl was like 13 or 14, very young. At the very end, he asked him how much. I want to say it was going to be like 250,000 shillings, which was almost like 80, 90 bucks, I think. $80 or $90 roughly, just to give you perspective, which is like, oh, to us, like $80, $90. Like my mom spent like $4,000, I think, on my teeth. Like, wow, that sounds so much better. But at the same time, I really doubt that you're getting proper techniques that we would be using over here, and I don't know exactly to the extent how well their orthodontistry would work. So that was an issue. But when he told him like that 200,000, 250,000 price, he instantly was like, no, like didn't even question it right away. That whole entire conversation was out the window. Like, no, you're pull her teeth, and it was her front teeth, so I felt like really bad, right? Like her adult teeth, like she wasn't gonna grow these back ever. And it pretty much just came down like, no, sorry, like we can't do it, like just pull the teeth. So he ended up pulling the teeth, and I felt bad because this girl's gonna walk around just like gap in her mouth the rest of her life. But it came back to that thing, like there's not much I can do, even though I really like would want to. It just can't. Your hands are locked. You just can't do it. Abscesses were a lot more common in their culture than they were ours. It was really weird. It was like not rare to see a person walking around with just a huge abscess on like the side of their mouth, and it was just kind of like normal to them. To hear, you'd be like freaking out. You'd be like, what the heck? Like you need to go see like a dentist or like a doctor like right away. Like it's like the size of like a grapefruit on the side of you, like coming out your jaw. And that was a pretty big issue that we'd see a lot in like a lot of the patients. The next one is their dry sockets are a lot different than ours. I don't know who's all had like root canals here, but when you get done with the root canal, the dentist will tell you no sucking out of straws, like smoking, all those things that like pretty much sucking of your mouth, like don't do that. Over there, it was weird because it was like all the dentist would tell them is like, don't take this piece of cotton out of your mouth for at least an hour, like at least. But they wouldn't listen, and as soon as they left, they would take it out, and then if you took out the cotton, you would form a dry socket. So then they'd be back like the next day complaining about not listening to the doctor's orders. And he's kind of like, well, what do I want me to do for you? Like, I told you not to do that, but you still did it. So it's that like challenge of like telling your patients like what to do, but they don't listen actually to what you want to do. And that creates kind of issues for the doctors that I didn't really think about as well. But here's a price breakdown, I guess, to show into this of exactly like what I guess the prices were. And these are more, this was for public health at like Iganga Hospital like we were at. It would still cost them $5,000 out of pocket that they would give to Dr. Paul like right before he took out or extracted their teeth. This braces right here was more of a private practice, so one of those like guys, I'd assume that's what he told me the price was. So as you can see, a lot like you have to be pretty like that's a lot of money for Ugandans to be able to do stuff like that. So that's why there's a limited orthodontry special like orthodontist out in there because you're not gonna make like a whole lot of money because there's not a whole lot of patients trying to get braces. The root canal, I think that was for public health. So these two are for public health. At how much it costs at Uganga Hospital, and like I said, I never saw any of those. I only saw dental extractions. That was the only thing I saw. They have all the equipment, just never gets used ever. Okay. Oh, I thought we went to the Okay. So just quickly wrap things up. This is like my. It's I want to be like this is kind of sensitive, I guess, a little bit. I'm not trying to say like that reservations. Well, first of all, I'm Native American. I'm from Fort Belknap Reservation. That's where I hope to go back and practice when I become a dentist and whatnot. But I don't want to say like what we have is as bad as they have it because it's just not. Like we have more resources around us and stuff. But there are a lot of similarities that I saw with just my growing up experience and applying it to this what we're observing in the Uganda hospital. A lot of it was probably just like education, like. There's a lack of education for Natives all around. And we have, if you ever like walk to like a reservation, even in Montana, you'll see a lot of the kids have silver teeth, and it's just because I don't know, like parents don't have them like brush their teeth, and they don't like, stress the need to floss and whatnot. So it's kind of stuff like that, education, and then the dentist to patient ratio as well. I think for Native people, it's one dentist per 39,000 people, so that wasn't as nearly as bad as theirs, but still that's a significant number. Trying to work on reducing that ratio a little bit. I guess I'll just wrap it up. Do I go to the very end?
Yeah, you see all the fun stuff we did on the weekend.
Just this is our first weekend. It was cool. This is like Jinja. This is like one of the scenic views, like the Nile River Explorers Camp that we stayed at. One of the scenic views. We got Rapid Nile at one point, go on a fun bruise cruise, have a little bit of fun, take some stress off of all the stuff, some of the things that were weighing us from seeing. We got to go to safari. This is the coolest thing, we got to go to the African Soup School, which was like a local development, our community development that Michael was the initiating pretty much, and it was in his own little hometown. It's like a boarding school kind of, right? Is that?
Yeah, it served like a catchment area around his village, but it was in his village in Namatumba.
Yeah,
Or Nabi Kabbalah, Namatuba, where we're going.
This was more like urban village area. This was really cool for us to do. We kind of wish we did it earlier because we really liked it a lot more. So our home life, where we stayed at, everything we did, kind of that's where we ate out in the backyard a lot.
Yeah, we lived like Ugandans, I think, for the most part, except for we didn't have to cook our own food. And a lot of
doing like our own laundry and stuff. That's our family members who hosted us. They're always around taking care of us. Kevin is the coolest little guy I've ever met. He was awesome. That's pretty much, we kind of want to talk about the food and stuff, but didn't really have time, so.
But what's next?
Quickly to wrap it up, this is our last little thing. What's next for us? For me, if you read my article, I'm going down to A.T. Still University. Well, A.T. Still University, it's called the Arizona School of Dentistry and Oral Health. I'll graduate here in May. Kick it over there in July, start school early July. There I'm gonna not only get my DMD, but also I'm gonna work at getting a Master's of Public Health. And
Yeah, and I'm gonna mess around in Uganda some more and try to do some more community health work and less just learning and more trying to actually do something. And learn that way. I guess.
Super jealous.
Before I go off to med school and bury myself in books some more. So,
Yeah. And then the last little bit is this is changing the life of one will change the life of generations. That's what Dr. Issa told me, and I wrote it down at one point because I just really have lived by that my whole life. I thought more so if I change one person's world, then I'm changing the entire world. And what's next for like the future Global Grizzlies? It's pretty much they're going back to Iganga General Hospital and they're gonna work and do everything we kind of did, but hopefully learn and observe more.
yeah, like what I talked about there at the beginning was like we want to change this into more forming lasting relationships, and so part of that is this year has been the first year that we're sending people back to the same place with the same NGO doing the same thing, with the hopes that over the course of more and more years we can kind of shift this from like everything we talked about to today was like what we learned. So we got like 90% of the benefit out of this trip and maybe gave back like 10% with some things we brought, some knowledge that we brought to them. But I think the goal is to shift that more into 50-50 where we can still learn a lot and learn all these things about Ugandan healthcare, but also maybe get together and put a community health project on or some sort of education to help and actually do something and make that impact a little bit more significant and help students learn more about how global public health is supposed to be done and how to make it more of a sustainable thing and less of just picking a country and going and doing the whole kind of volunteerism thing. And so we've had some great students, one of them's here today, that have been really on board with this vision, and I think we're really moving forward as a group to turn it into something that we can be even more proud of going into the future with what Global Grizzlies can do in 2018, 2019, 2020, and on.
Just kind of wrap up, that just kind of stems from Professor Kern's help in global public health. Got us really interested in the field, and hopefully we're interesting students of the future to do that as well. And we have a lot more plans than just that, but it's all we have time for, kind of. So, any questions quickly to wrap it up or anything?
While you got that up, what is Global Grizzlies? Is it a club? I mean, you said somebody selected you? Is
Yeah.
it healthcare? What is Global Grizzlies?
Student-run student group, ASUM, through the Davidson Honors College. This year we are the mentors to these students and helping them prepare for their trip and teach them about what we learned about Ugandan culture and help them plan for a international trip, because like us, many students who do Global Grizzlies haven't ever done any sort of overseas travel or been to a developing country or anything. And so, yeah, what excites me about it is that it is student-led and that students are taking the initiative to try to figure out how to do work like this. So it's been around since 2008. It's been
Are
going
there
on
other
for 10
groups?
years.
It's like this is the healthcare group and there's other emphasis on.
This is the only one.
It's
Yeah.
always oriented to healthcare?
It's just kind of gone down that road. In 2008 when it started, there was like anthropology kind of and going community health. Like we had community health, there's community health this year, but it's kind of just funneled down into this, like the people who have been interested in it have been like pre-professional, pre-med, pre-PA, pre-PT. So that's kind of just where the group has naturally flowed to.
In your personal opinions, what were the most interesting low-tech solutions to common problems that you saw in the hospital? Like the whistle was pretty interesting.
Yeah, they were really good hands-on, doing things with their hands. So things like we all brought stethoscopes. One of our group mates brought a Littmann, and like the doctors were constantly like asking them to use a stethoscope because they didn't have one. And so they were very good at like being able to tell like where fluid was in someone's abdomen or in their chest, and it just seemed like because they didn't have the technology to assist them, they couldn't just ultrasound something. They got really good. Just like their hands were the most impressive thing to me.
Keith?
I think mine kind of follows along suit with that. I think it was just more so the fact that like, they didn't have these ways to scan or take X-rays or like stuff that we would have a resource like any doctor like could do kind of, I guess. But they figured out ways of doing it, just like Andrew said, by like palpations, and it was really interesting to figure out these ways that they understood how the body worked, I guess, without having the resources and the education that we do in other areas. So it was just like their natural just ability to help in any way, just through the use of their hands pretty much, because that's all they had.
I think we saw like 3 broken femurs while we were there, and patients would just sit on ward with their femur in traction for like 2 months straight. And they didn't have like the traction devices we have, but they just like took something up to their ankle, put a string, and hang a weight over a bed. Like that was their traction. Like things like that it was just like, that's cool.
So we have time for, I think, maybe 2 more questions, and go ahead, Jose.
Maybe the flip side to that question, you having a background from the US and from your experience there, what do you think is sort of the low-hanging fruit? Or if you became the director tomorrow for a couple of years of that hospital, what would you do if you didn't have any extra resources? What kind of changes would you do to the hospital?
That's a pretty loaded question.
Like what would you cut? What would you like?
What would you do different if you were in charge of everybody who was there with the resources that are there?
I think there was just a lot, like, there wasn't a good hierarchy of people whose responsibility was to watch over someone else, whose responsibility was to watch over someone else. So, like, coming from the US where that's like the norm, I think I'd want to have more of a organizational structure where I have an administrator who's making sure my doctors aren't taking bribes and making patients pay for services that are supposed to be free. And I'm going to have doctors who are actually watching over my nursing students and medical students while they're doing all these practices that they had barely been able to learn in the first place. So I think just like that supervision of at every level, it seemed like with what they had, like I think that was one thing that could have easily been improved, but just with the way culturally they look at work and things like that, it just wasn't there.
I would just kind of say, like, go along with that, just like ethics, just try to implement like some sort of like medical ethical background or education into like their staff members. I think that was kind of lacking, and so I don't think that wasn't really lacking. It's just like they haven't really thought about it yet. They're not at that point of their medicine, I guess. So that's what I think I'd go approach from. We have one more question, Tom.
Yeah, question for both of you. What's the main thing you took away from the experience?
The main thing I took away, and I mean, like I don't know, it's just like how, it's pretty cliche, but how happy they really were, generally, like speaking. I mean, I've always been a person who thought that money didn't create happiness. It also creates financial stability. It makes you like, it's good to be able to like pay for all these things in your life and whatnot, but realistically, like, these people didn't have like any money or anything to their name, and they would still wake up and smile, have a reason to live every day. And I think that translates to us today. It's like, as a country, it seems like we have really big mental health issues going on right now, and it's weird because you think that we have everything at our disposal and everything we need, but yet there's this lack of true happiness within each individual. So it was really nice to see like them who just would come in with the biggest smiles on their face, make me smile even bigger every day, and just bring that positive mentality to what their daily life is all.
Yeah, he took mine because that's what I'd say to everybody ever is like how happy everyone was. But the thing that I thought went along well with that was like just the way that collectivism can help when you guys, like everyone in the community is working against the same problems, same issues, and they really have this collectivist kind of community that everyone's willing to help everybody. No one's trying to put someone else down for the most part. And versus like in our country and in our medical system, it seems like a lot of people are looking out for themselves, looking out for their paycheck, trying to get forward in their career. And there it seemed like it was very much so a community, and even especially in the healthcare, in the hospital, like it was a community. The staff seemed like family. And I really wish like more that I shadow and stuff here, like I would love to see that more as well.
I really want to thank both of you because it's really been very interesting and informative to hear your perspective and to learn about all the things that you learned and observed while you were there. I would just add my own point on if you are going to do something in the future to make a contribution, it might be in the area of public health education. That might be a good role to be thinking about, because you talked about how people didn't even know how to use the dentist chair. I mean, there's a lot of things I think that could be done there, and reaching out maybe into some of the rural areas outside of Uganda as well.
That's exactly where we're looking, I think.
Something to think about.
Right, Bryn?
All right, well, we haven't had a chance to give these guys a round of applause. Let's really amp it up. Thanks a lot. And for next week, we have Libby Lack, who's a PA with Dermatology Associates in Charlottesville, and she's going to be talking about treating poverty as illness, my experiences in Haiti.